once.
All right. Good morning, everyone. We don't want to start too late this day. There's a bit of a party happening tonight, so let's get through the program. And I think we've got the best session starting here this morning. So welcome, everyone, to the Louis Sheiner Student Award session. I'm Stephanie Hennig, Senior Director at Cetara, and my selection committee panel members and colleagues are
Maria Kjellson, Associate Professor at Uppsala University.
And I am Alo Denti, Professor at the University of Cape Town.
Okay. Good. So let's start with the first speaker. As you can see, we had the honor and the pleasure of selecting 4 outstanding students based on their abstracts for this award. We are all very excited to listen to their talks now after reading the abstracts, and I hope you're all excited as well. Each student will have 20 minutes of talk time, followed by 5 minutes of questions after the presentations. We're going to start with Conor O'Holland. He probably had the furthest way to travel here to Page, and it's actually his first time at Page as well. He came all the way from New Zealand, so please make him feel extra welcome. Conor's background is in pharmacology, where he completed his honours degree at the University of Auckland in New Zealand. He completed a PhD in clinical pharmacology with a focus on pediatrics, cardiopulmonary bypass, and renal function. For him personally, the main highlight of his project has been able to be involved with different parts of clinical studies, from patient recruitment to bioanalysis to modeling the data. So as I said, it's his first time here at Page, so Conor will be giving a talk called A Framework of Drug Pharmacokinetics During Cardiopulmonary Bypass. Welcome, Conor.
Thanks very much for that introduction, Stephanie. So as she said, my name is Conor Hanlon from the Department of Pharmacology and Clinical Pharmacology, University of Auckland in New Zealand. My name might be a bit more tricky to remember. It doesn't begin with Alex, unlike the next 3 speakers. But today I'll be giving a talk about a framework for drug pharmacokinetics during cardiopulmonary bypass. So cardiopulmonary bypass is an extracorporeal medical procedure used to replace heart and lung function. This photograph shows a photo of a device. It's quite a complex device with components with various functions used to support life during the procedure, including a central venous reservoir, oxygenator, and various conduit tubing. This complex procedure also involves major physiological changes and events, including stopping of the heart using a potassium solution called cardioplegia. This solution stops the heart and allows the surgery to take place on a still and bloodless field. During the surgery, it's also possible that drugs administered may adsorb to the internal surface of the device. And then this raises questions for drug pharmacokinetics about how much absorbs and is this clinically relevant. Further questions also raised about what is the effect of this complex device and procedure on drug pharmacokinetics. So cardiac surgery supported by CPB is a major and invasive surgery, and so requires antimicrobial prophylaxis to prevent surgical site infections. And one such antibiotic used for this is cafazolin, which is a beta-lactam, administered IV. It's renally eliminated and highly plasma protein bound to albumin. So the patient is usually dosed with cafazolin for the first surgical incision and then throughout the surgery. And a priming dose of cafazolin is also administered into the CPB device circuit prior to connection to the patient, and it usually occurs about half an hour prior to this point. The CPB devices come in different sizes suitable for neonates all the way up to adults. as well as different coatings of the internal surface of the device, which I'll be discussing in more detail shortly. So the aims of this work was to describe population pharmacokinetics of clofazolin in neonates, infants, and children undergoing cardiac surgery supported by CPB, with key focus on does CPB impact the population pharmacokinetics, and is this change clinically relevant? Then secondly, to quantify the clofazolin absorption, if any, to the CPB devices, and discussing how much is actually bound, and again, is this absorption clinically relevant? And then using this framework to see if the findings can be generalized to other drugs, using an example of application to vancomycin. So this work consisted of two studies, an ex vivo and an in vivo study. This diagram shows a simplification of the photo I showed of the CPB device earlier, of various components of the CPB circuit. In the ex vivo study, 12 closed CPB devices, so not connected to a patient, were primed and dosed with antibiotic, and samples taken at regular intervals over 1 hour. Because it's a closed system, we don't expect the concentrations to change over time, so any changes could be due to antibiotic adsorption. Next, we have the in vivo study, which involved recruitment of 50 neonates, infants, and children who underwent cardiac surgery supported by CPB, and looking at population pharmacokinetics in this population. This involved incorporating information from the ex vivo study, as well as other functions and procedures that occurred during the surgery, such as filtration processes, which provide an additional source of elimination for some types of drugs. So moving on to adsorption to the CPB devices. Antibiotic adsorption could occur in the tubing of the device or any of the components of the device. Coatings of the internal surface of the device reduce cellular and protein adhesion and prevent thrombi formation. These coatings also reduce the interaction between drugs and the polymer surface of the device. However, activation of coagulation and inflammatory pathways still occur because these coatings are not perfectly biocompatible. Drugs that are highly plasma protein bound have also shown greater adsorption to CPB devices. Many studies have already investigated adsorption of drugs, of different drug classes, to CPB or ECMO devices, but these often report a percentage adsorbed at the end of a specified time period. A more mechanistic approach could describe the time course of adsorption based on the time course of drug concentration in the device, association and dissociation of the drug to and from the device surface, and also a maximum binding capacity of the device. So the main factors influencing adsorption are device size and coating type. Device sizes are available from neonate up until adult sizes and are selected clinically based on the patient's age and size. There are also numerous coatings available that are designed to decrease adsorption, and the ones in this study looked at X coating, which is a polyacrylate type coating, Rioparin and heparin type coating, and also a physio, which is a phosphorylcholine type coating. The matrices are used in the study also ranged from Plasmolite, which is a crystalloid fluid replacement solution, or a blood-based priming solution, so either packed red blood cells or whole blood. And these are not expected to affect the absorption, which we'll be discussing shortly. So in terms of the structural model, the drug disposition was described using a one-compartment model with no clearance elimination. Partitioning of clofazolin into the red blood cells was accounted for using an equilibration rate constant. Binding to the device and absorption to the device and binding to plasma proteins were modeled using association and dissociation rate constants, which were parameterized in terms of Kd, the dissociation constant, and T2 off, which is the half-life of dissociation, to improve the interpretability of the parameter estimates. An additional volume of cardioplegia was added to some experimental runs, and which has added volume to the central compartment. Drug was eliminated from the closed system only through loss by sampling from three main components: unbound drug in the device volume, unbound drug partitioned into red blood cells, and also drug bound to plasma albumin plasma proteins. The model used to characterize the pharmacokinetics is influenced by the plasma type through partitioning into red blood cells or plasma protein binding. However, the absorption part of the model, which is the key area we're interested in, is not affected by the matrix choice. So looking on to some of the main results from the ex vivo study, the device size and device coating were the main factors describing the rate and extent of adsorption. Device-specific Bmax parameters and coating-specific KD and T2 off parameters were estimated. X-coating, cafazolin had a lower binding affinity for X-coating compared to physio and rioparin. In physio and rioparin device types, the binding parameters weren't distinguishable between these two coating types. And also X-coating had equilibrates much slower than the physio or rioparin device coatings. We also had data available from some experimental runs using vancomycin. Vancomycin is also sometimes administered for surgical antimicrobial prophylaxis, and it's moderately protein-bound. The ex vivo framework that we had for cafazolin described the vancomycin data well, with no changes required except for estimation of vancomycin-specific binding parameters. The main difference which we saw from cafazolin and vancomycin is a much lower maximum binding capacity in vancomycin. So moving on to the CPB in vivo study. This was a population PK study involving 50 neonates, infants, and children undergoing cardiac surgery supported by CPB. They ranged from 3 days postnatal age up to 14 years, and between 11 and 22 samples collected per patient, so quite a rich sampling schedule. And the number of samples depended on both the patient's size and the length of the surgery. So on the right, we have a simulated concentration time profile, just to give you an idea of the major events occurring. So prior to skin incision, there's a dose of cafazolin. At some point between then and the start of CPB, the CPB device will be primed with cafazolin. And then once CPB is commenced, it effectively delivers another dose of cafazolin to the patient. And then later on, the CPB will end and another filtration process will begin, which I'll discuss soon. So unbound cafazolin and total concentrations were quantified. The unbound concentrations were used to estimate the PK parameters, and the total concentrations were used to estimate the binding parameters. So looking now at the structural model for the in vivo clinical study. So the input was described with a short infusion either into the central compartment of the patient or in the priming dose into the CPB device, usually around half an hour before the patient's connected to the system. Cafazolin pharmacokinetics were described using a two-compartment model with this additional CPB device compartment, which is switched on when the patient is connected to the CPB machine. There's a small amount of partitioning into the red blood cells, both in the patient and also in the device when a blood-based priming solution is used. And adsorption to the device is described using the kinetic binding model from the ex vivo study. Cafazolin was eliminated via first-order elimination from the patient, but also there are two other elimination processes that occur. The first on the left, hemofiltration, which is a filtration process that occurs throughout cardiac surgery. And then a second filtration process called modified ultrafiltration, which occurs once the bypass procedure is finished. It involves reversal of the flow of the device and is commonly used in neonates and infants because they undergo relatively more hemodilution compared to children and adults. We collected samples both from the patient and the CPB device during surgery, and also the ultrafiltrate from both filtration processes was collected and a sample taken at the end of surgery. In terms of the covariate model, the population parameters were scaled for size using theory-based ceilometry. Normal fat mass was used as a metric for size that also can account for body composition. A sigmoidal maturation function was used to account for changes in clearance in neonates and infants attributed to development. And a metric for renal function described using the ratio of estimated to normal glomerular filtration rate using a serum creatinine measurement before and after surgery was used to describe the renal function. This metric for renal function then accounts for size, body composition, and maturation consistently, and so a value of 1 indicates normal or expected renal function for that subject. The other key point is factors for the impact of cardiopulmonary bypass. These factors were estimated on each of the structural parameters at the time that CPB was commenced. So looking to some of the key parameters from the model, there was a decrease in clearance of about 34% at the time CPB was initiated, which persisted throughout surgery and also in the short time we had samples for after surgery. So this could be related to hemostatic or physiological changes caused by CPB and probably specifically changes in renal perfusion. There's also an increase in both the central and peripheral volume at the commencement of bypass. A single saturable binding site described cafazolin plasma protein binding to albumin. Population PK parameter and data approach, sequential approach was used to prevent bias in the unbound parameters caused by any binding model misspecification. Also on the right have the VPCs for the unbound on the top and the total on the bottom cafazolin concentrations, with the 5th, the median, and the 95th percentiles of the predictions and observations, and the 95% confidence intervals around the predictions in the purple shaded area. And so these VPCs show that the predictions are well captured by the observations. So now we come to the clinical relevance of the CPB absorption, and specifically how much of the total cafazolin dose is absorbed to the device at the end of the CPB procedure. So you can see from this table, I've got some typical total doses used with various device sizes and coating types. You can see for basically all coating types, the percentage of the total dose, so that includes the dose to the patient beforehand and the priming dose, is less than 10% in all cases, and so it's unlikely to be very clinically relevant. In terms of the time course of drug absorption, typical CPB duration is around about 2 hours. In terms of the time course of drug absorption, this is not very important for the rheoparin and physio coatings because they equilibrate very rapidly, but it is more important for the X-coating type with a much slower dissociation. Typical unbound concentration achieved during cardiac surgery of cafazolin is around 37 milligrams per liter. And again, this means that both rheoparin and physio device coatings saturate rapidly with high affinity, but the KD dissociation constant estimate for X-coating is within the clinically relevant concentration range for cafazolin, and so the time course becomes more important for the X-coating. So in conclusion, cardiopulmonary bypass impacts cafazolin pharmacokinetics. It reduced clearance and increased volume above what could be explained by changes in size, maturation, renal function, and additional volume from the CPB device. It reduced clearance by around 34%, which might be clinically important for drugs depending on the dosing regimen. The duration is unknown because we only had limited samples after the end of the surgical procedure, but other work we've looked at, looking at milrinone, another renally eliminated drug given after CPB, showed a return to baseline clearance of about 11 hours, and so we might hypothesize that cafazolin follows the same time course of return to baseline, and so might be back to normal in between 1 to 2 days. In terms of the device absorption, that was determined by the device size and coating type, but Bmax was small relative to the patient doses clinically, and so it's unimportant for all device types. That is to say, it wouldn't require a dose adjustment based solely on the extent of drug absorption. However, it is useful to describe variability in the PK parameters attributed to these absorption processes. About 8% of a typical dose for adult and 6% of a typical dose to infant was absorbed, which is saturable and basically occurs at all cases at clinically relevant doses. However, the absorption to the X-coating device depends more on the patient concentration time course. We also had data to evaluate the ex vivo framework with vancomycin, and this was able to describe vancomycin absorption, and which also suggests that the framework could be extended to other PK studies involving CPB. So I'd like to thank my supervisory team, Jacqueline Hannum, Nick Holford, Malcolm Tingle, and Brian Anderson, as well as research colleagues who collaborated with this study. To acknowledge the funding providers for the study, Australia and New Zealand College of Anaesthetists, University of Auckland, also to Paige for a travel grant and Icon for a non-member license, and perhaps most importantly, the patients and families involved in the clinical study. Thank you.
Thank you very much, Connor. This presentation is now open for question. If you can come up to the microphones, very closely to the microphones, and start in introducing yourself before you ask the question, that would be great. Thank you. Yes, please.
Good morning, Stefan Schmidt, University of Florida. As far as I know, there is two types of supplements that can be used, so crystalloids, such as you've done in the study, or albumin. Do you have any expectations of how your results may look like if albumin were used?
Yep, so we did, we had some runs that used whole blood that also had albumin in it, and it's actually as well as albumin alone in one of the runs, and so there was no effect of albumin in and of itself on the adsorption, but we did account for the plasma protein binding to albumin in those runs.
Thank you. Second question I had was, usually for cephalosporins, such as cefazolin, time above the or unbound time above the MIC is the PKPD index used in the clinic. So given that you have, let's say, 34% change in clearance and absorption like 6% or less of the dose, relative to the twofold measurement error in MIC, what are your expectations how this is going to impact your probability of target attainment?
Yep, so I did, there's a whole another section of this work looking at probability of target attainment, which I haven't presented here, basically, with the dosing regimen that we used in our centre, that it was actually okay, even with the reduction in clearance. Actually, the reduction in clearance basically helps the concentration stays above the MIC a bit longer. Yeah.
Good job.
Thank you.
Can you hear me? Hello? Yeah. Hi, so it's Path from Genmab, the Netherlands. I wanted to ask you in regards to total body cooling, and did you look at that as a parameter for return to baseline, if that also had an impact, or?
Yep, so for the ex vivo study, we looked at temperature and to see if that affected the adsorption. We couldn't find any effect. We actually did reduce the temperatures down quite low to what's seen clinically. Mm-hmm. We thought there might have been an effect, but we didn't find one.
Fantastic. Great work. Thank you.
If there are no questions, I may have one.
Sure.
So you have this very complex and elegant model. You said that overall the dosing regimen that is already used in the clinic works. Mm-hmm. But if you were to optimize the dosing further, have you thought that far, and how are you going to convince the doctors to trust your complex model and make it simple to dose?
Yeah, I think for cefazolin in particular, we found that the dosing regimen was achieving the target time above MIC. But in terms of this work, it was more that there might be other drugs which may absorb more, which may require a dose adjustment based on the absorption. And so this can provide a framework where you can look at that and quantify that absorption to provide the dosing adjustment.
Thank you very much, Connor, for an excellent talk.
So the second speaker of this session is Alexander Johnson. He started his PhD in 2020 when the pandemic just started as well. He didn't have any background in pharmacometrics, so he took the starting of this lockdown to actually read as much as possible about the topic. He comes from a background with machine learning, and the combination of starting with pharmacometrics and machine learning has spurred his interest in this field, and is related obviously to the presentation that we will listen here today. So Alexander has kept up his motivation of the science, both of the interest in the topic, but also with all the nice friends that he met along the way, not the least at Paige here. So welcome on the stage to give you a presentation entitled A Generative and Causal Pharmacokinetic Model for Hemophilia A, towards a unified model for all factor VIII concentrates. Welcome.
I'm sorry for having to struggle my way up the stage. Unfortunately, I was one of the latest victims of the Cetera football game yesterday. My ankle is as large as a tennis ball, so hopefully I haven't fallen on my head too hard. So I first want to say my thanks to the organizing committee and Louis Sheiner Student Selection Committee. I'm very honored to be able to present my work here on a generative and causal pharmacokinetic model for hemophilia A. I'll start off with some background on hemophilia. So hemophilia is a rare and X-linked inherited bleeding disorder. It's characterized by either a dysfunctional or deficiency in the blood clotting factor VIII, which results in increased spontaneous bleeding. And essentially what we do, we give these patients replacement therapy using prophylaxis with recombinant factor VIII concentrates. And since then, there have been many clinical guidelines that advise the use of PK-guided dosing rather than something like weight-based dosing. And that looks something like this. Essentially, you have a patient coming in. We give them a test dose of one of the factor VIII concentrates, and then we measure factor VIII levels. This is probably quite common for all of you. But say in an example, we have a patient with a relatively long half-life, means that we are happy, we can be quite efficient at dosing and treating this patient, and there's not much wrong. However, it's also perfectly possible that the patient has a poor half-life. In this case, it becomes more difficult to do an efficient way to dose the patient. These concentrates are relatively expensive, so we would be thinking about increasing the dosage, increasing the frequency. Increasing the frequency is often something the patient doesn't want. They're already getting 2 to 3 doses each week. So what we also might want to consider is actually, can we give them a different drug? And of course, we can do another test dose, but there's information in the previous PK profile, and can we use the information in those profiles as well to predict for a different drug? Well, unfortunately, hemophilia PK models are frequently built on relatively small populations. It's a rare disease. Usually they're specific to a single drug, so we would have to switch to a different PK model in order to predict for different drugs. And usually they're also relatively simple in that usually just include the effect of weight via, for example, allometric scaling, or we're actually missing known important causal covariates, such as von Willebrand factor. Usually what we do instead is include stuff that's correlated to von Willebrand factor, like age and blood group, but we know there's likely no direct causal effect there. And another problem that we have is that there's these differences between measurement assays. So essentially putting that all together is a recipe for difficulties when trying to extrapolate to other drugs and use different PK models on the same population, because lots of sources of bias that can enter there. So we try to take a different approach. So essentially we have these 3 steps in our modeling plan. We start off with writing down what's called a causal diagram. And essentially what that allows us to do is visualize all the relationships between the covariates and perform covariate selection, and also think about or identify covariates that we could consider to be confounders. So that's either things we should control for or either things that we shouldn't be controlling for. And next, what we propose to do is to then develop something that's called a generative AI model. You've all used ChatGPT. Essentially, this is something for covariates. And what that allows us to do is to impute missing data and simulate realistic patients. And then thirdly, based on the causal diagram, we will develop a causal model, essentially that also controls not only for the PK or differences between different drugs, but also for the measurement assays. So I'm going to be jointly discussing methods and results. There's a lot happening, so I'll first go over the method and then directly to the result and then move along. So firstly, about describing those causal relationships, we use a causal inference tool called directed acyclic graphs, which is in shorthand DAGs. I will be using that because otherwise I will never make the 20 minutes. Essentially what they are visual representations of the relationship between covariates either assumed or known relationships. And below in the slide here, there's an example, an X with an arrow pointing towards Y, which we should be reading as X causes Y, which for many of us is already a very scary statement. And we can inform the development of these graphs by previous literature. So I don't want you to be looking at everything on this slide, but just to have like an image of how a DAG would look. We made it a specific one for the generative model and the pharmacokinetic model. Obviously, the covariates are linked between either of them, but as I'll go along, I'll get some components of this DAG and discuss them further. So this is an overview of the entire modeling strategy. Again, there's a lot happening. Essentially, what you should know about this is essentially we have a training set of patients treated with drug A and measurement SA1, and we want to move over and predict for a different drug and a different measurement assay. And so we got all these steps in between. And I'll start off with how we developed the generative model. So essentially, to create a generative model, we need some data, but the more the better, of course. So we used data from the NHANES data set, which is a large survey in America that collects a lot of data about the general population. Essentially, the only things we need here are the patient age, weight, and height. But since there's like almost 1,700 patients, it's quite a nice data set to see the correlation between these covariates. And then what we did as well is collect information about patient age from virulent factor and blood group based on previously published data. So essentially we used a webplot digitizer to collect all the points from many figures in order to get some data on the relationship between those three covariates as well. And what we'll then end up doing is learning the conditional relationships for each of the covariates using something like neural networks for relatively simple distributions, and for more complex distributions we use normalizing flows. Don't worry about how that works. Let's just look at what comes out of those models. For example, here we have the causal, a part of the causal graph, moving from age into height into weight. So essentially what we can do, we can grab something like a covariate of age and then predict the conditional relationship with something like height. And this is a relatively simple relationship, as you can see. We can use a neural network to fit this and then essentially fit a normal distribution over the different values of age. So we get these distributions from which we can actually get samples. And this is an example of something easy, like for which we can use neural networks. Of course, there are more difficult relationships as well. So here we have the relationship between weight and height. You can see it's clearly more and more linear than the previous example. And essentially we use normalizing flows here because we need to interpolate between a normal distribution and a log normal distribution. And normalizing flows is a very convenient machine learning tool to do these kinds of correlations. Of course, we can also move in the backward direction, but just for the sake of time, I won't show all the components. So back to the modeling strategy. Now we have our generative model done, and we'll move over to the predictive PK model. So remember here that we have a training set for drug A. We got this data set from CSL Behring, very kindly provided it to us. It's a relatively large data set with 120 patients. The covariates were age, weight, height, and von Willebrand factor. It was a clinical trial, so they collected lots of samples, which is very nice for us, of course. And as I said before, the levels were measured with the factor VIII levels were measured with two different assays, so we can learn some sort of conversion between those. And essentially, we fit a machine learning model and, to this data, and we monitor the overfitting during training and select the model before we see the model overfitting. Part of the patients in this data set also received standard factor VIII, so we can also use this data to learn some sort of conversion between those two types of products. So how do we actually do the PK here? We use a machine learning-based technique called deep compartment models. to learn the covariate effects from the data. Essentially what this is it's a neural network that predicts the parameters for an ordinary differential equation. The ordinary differential equation is essentially a compartment model, so we essentially have a neural network learning to predict our PK parameters based on the covariates, which of course is known to all of us. Essentially now we're doing it in an automated way by using neural networks. So we fit a two-compartment model, have simple additive error, and add random effects on the clearance and volume of distribution parameters. And again, we do the covariate selection based on the causal DAG. So we use a special architecture for this model. Essentially what's happening here is that as we have our trained model, it actually consists of several submodels. So we can take one of those submodels and essentially, for example, if we just input a single covariate, that means we can enter dummy data into the neural network and essentially visualize the learned function, which we can use to interpret the data. So here again is a part of the causal graph. Essentially, we predict the clearance and volume of distribution based on the patient height and weight. We assume that these are not necessarily directly linked, but work through these latent variables. It's called Z in the figure. And you can think of something like this to be the plasma volume or something like that. Factor 8 is essentially mostly distributing to plasma. And for clearance, we also use von Willebrand factor levels. This is quite known to be causal, and we want to avoid using things like age and blood group. So essentially, we see that the model fits quite nicely based on the Kuhn-Fit fit plot. The root mean squared error, which is a measure of the discrepancy with the training data, is quite nice. The coefficients of variations are also relatively low, which we like, and the residual error is also quite expected. Okay, so how would the model interpretation look like? Here we have, for example, the relationship between von Willebrand factor levels and clearance. In the top part, you see a histogram with the distribution of the data, and in the below graph, you see the learned effect by the neural network. And essentially what we see is that at lower von Willebrand factor levels, we see a sharp increase in clearance, and it's expected since von Willebrand factor is actually a protein that protects factor 8 from degradation. So you would expect lower levels to lead to higher clearance. And as the von Willebrand factor levels increase further, we see a diminished effect the diminished protective effect of von Willebrand factor levels. Could be indicative of some sort of plateau to its effect. So now we have a PK model. We can move on to predicting the difference between different factor 8 concentrates. So essentially what we did, we used the 27 patients who also received standard factor 8 to predict the factor difference in the typical PK parameters. And essentially what we find there is that standard factor 8 concentrates have a lower half-life, which is something that's also supported by previous literature. The next step is doing the assay conversion. So essentially we have the CSA, which is chromogenic assay, and OSA, which is one-stage assay. And it's also quite well known from the literature that CSA levels are generally higher than OSA levels, and we can fit a conversion factor for that as well. Then we're ready for the testing of the data. Remember, this is a different, we have to predict for a different drug and a different assay here. And we essentially collected an independent data set that was collected during a study that we did. 43 patients, of which 50% had missing von Willebrand factor levels. That means that we really need to use the generative model here to help us impute that missing data. And the patients in this data set received either standard factor 8 or beta domain truncated factor 8, and these are known to have relatively similar PK. There's not been much indication that there's a clinically relevant difference between these two. As I said before, these were measured using the one-stage assay, so we also need to do the conversion with the assay. Again, we compared the performance in terms of root mean squared error between our model and 4 previously published nonlinear mixed effects models that were actually trained on one-stage data and actually on standard factor 8 using covariates such as weight, height, age. Some of the models also tried to include the effect of von Willebrand factor, but ended up discarding it. It was clinically significant, which it should be causal, so I think you should include it anyway. So when we look at the comparison here, in the top 4 rows, you have the previous nonlinear mixed effects models. You see most of them are trained on standard factor 8, and essentially what we see is that the root mean squared error is lowest for our model, both on the patients on which we actually know the von Willebrand factor levels, as well as on all the patients, meaning that the generative model is also quite nicely imputing those missing data. What I didn't have the time to show is that we also validated the entire generative model based on the accuracy of imputing all their missing data, but just for the sake of time, I won't be showing that today. Then we move on to the discussion. So a question that is very valid, especially in the context of causal inference, is, well, why do we need to create a DAG, right? So it's just some lines and some variables. Of course, we should know all of this. Essentially, it's a nice framework to get a visual representation of what the covariates are actually doing, what their correlations are, what we expect to be happening. And a very useful component of that is that there is actually specific shapes of these relationships that can be used to identify confounders. And in our case, we could identify age and blood group as potential confounders because age is both correlated to von Willebrand factor levels and patient height, so that could mess up our model. And if you have a correct DAG, you can actually enable counterfactual analysis. Like if you're correctly correcting for all the covariates that are important for the variability, you do so correctly, then you should be able to just change one of the covariates and see what that does with the prediction. So why would we add probabilistic generative models to that? Well, of course, I think most of you would like the possibilities of imputing missing data without having to think about the method to do that with. And we can show that this works actually quite nicely, and you can fit this using machine learning, so it's fully automated as well. And another nice component of this is that we can use these generative models instead of like our actual data set and just share the generative model. So it's also a nice way to share data. And another thing we can do is use the generative model to identify the patient cohort and see if new patients match the patient cohort used to train those models. Now we come to another question. Why did we use machine learning for this? The von Willebrand factor level relationships were not that complicated. We can, figure out a function ourselves. Well, essentially the nice thing here is based on all these sources of variability, we likely have insufficient data when we just use a single data set. There's lots of different factor 8 concentrates, there's lots of measurement assays. Essentially what we want to do is want to keep training this model. And what we can do to solve that issue is to set up an offline federated learning approach. And essentially what that is you keep the data private at each hospital, for example, and essentially you share the model around. You keep training that locally and then upload the learned parameters to a central entity that then builds on that model. And using these generative models can allow us to share the data roughly that it was trained on as well. And since the entire process is now automated using machine learning, it's not difficult for new entities to actually do this. This is like a rough schematic of how that roughly would look. So essentially when you have trained multiple models, you have this model pool. Essentially the area you see here is the support for a specific group of patients. So if you have a new patient marked at X, we can see that model 3 is definitely not appropriate for these patients, but model 2 and model 1 are, and since we use probabilistic methods, we can derive a likelihood function which model would work best, and we can do an actual weighted prediction of both models to hopefully get a better prediction than either of the models on their own. That was essentially what I wanted to speak to you about. I want to acknowledge my colleagues, Ron Matteau, Marion Knossen, Michael Kloesmeijer, Sjoerd Koopman, and Frank Bennis, two of which are here today. I also want to thank all the members of the Symphony Consortium and the Optical Study Group, which are on the picture there, and all our clinical partners. Thank you.
So this presentation is now open for questions. Please come to the microphone and state your affiliation and your name, please.
My affiliation is the University of Auckland. My name is Nick Holford. And that was a really fascinating talk. Completely new to me. The idea of causality was really interesting. And I have a question about causality. You say that age is causal, but as I tried to say yesterday, age is just a ticking of a clock. It can never actually cause anything. So is it really causal? The next step was to say that age causes height, and then height causes weight. So would you like to explain in more mechanistic terms why you use those particular causal relationships in that sequence and not, for instance, weight causing height?
Yes. Essentially, the reason we took this approach, essentially with age, there's a change in height over time. So yeah, you could argue
and weight
with being age being there likely are steps in between, but just to get the actual complete diagram not completely filled with intermittent steps, we essentially just do the shortcut from age into height, and essentially for the relationship to height towards weight, weight increases because the size, the literal skeleton increases in size. In that way it's correlated. There's other components in there as well. For example, we have causal relationships with diet and lifestyle and stuff on weight.
Did you try changing the causal relationship and, for instance, making weight causing height? It seems to me more plausible because if you don't put on weight, you're not going to grow, you're not going to get longer. So did you try changing your assumptions about causality to see if it would change anything about your model?
Well, we don't. Essentially, we fit also the reverse relationship. So we do fit a probabilistic model for weight into height. So we can also use that pathway. Essentially, that side of the model is not really important for the actual causal PK model.
Okay. So just another question, a completely different thing. You started out referring to a patient with a poor half-life. I assume there are patients with rich half-lives as well.
Yes. We hope so,
but the context of that, from what I understood, was that you were perhaps planning to use this model to be able to use the first dose the patient got to predict what the next dose should be for the same patient. So a clinical application of the model. Yes. Have you made that step, or are you planning to make that step?
We are planning to do it, yes. We've recently got a subsidy from the EU to do this, to try this federated learning approach in several pediatric hospitals in Europe. And so what we essentially want to do is identify additional covariates, hopefully, since, there are differences between products in the terms of their binding capacity to formulaband factor. So that's differences that are...
Okay, so it's fine. I mean, you might polish it up a little bit, but the goal is to actually improve patient treatment.
Yes.
Okay, good. Thank you very much.
Thank you very much for a super interesting presentation. I'm Siv Jönsson from Uppsala University and Prometheus. So I have a less philosophical question than Nick had, and very, very basic. So I'm not at all into this type of machine learning methods. And so I wonder, what kind of software do you use for all those different DAGs and generative model, blah, blah, blah?
The DAGs I made by hand. There's also lots of R packages that essentially make it really easy to create those DAGs. Essentially, you just type out a string and you get a nice figure like this. And in terms of generative models, I use Julia, but it doesn't really matter what programming language you would use. Essentially, any program that supports machine learning can actually do this. And we're planning to make this all publicly available, so you don't even have to, since the weight-height relationships, those are quite common, and that can be used by anyone. So I think that's quite ready for anyone to use.
Okay, thank you.
One last quick question.
Nadia Terranova, Merck AGA. Thanks for the nice talk. I have a question about your generative models. If I well understood, you're just generating for few covariates, probably baseline covariates, not time varying. Do you have any experience with generative models generating over time covariates or like response data?
Yes, very good question. That's, of course, I think that is really something that could do a lot for lots of drugs. We're currently looking at vancomycin in ICU patients. Essentially what we want to do there is learn the change in something like creatinine over time. Since currently what we're doing is we have these isolated creatinine measurements, and it's very much correlated with vancomycin clearance, but essentially when we measure a super low creatinine value, that means the clearance has been super high, but after that point it hasn't, or it likely will start rising. So we want to interpolate between all the points, and essentially that would give us something like a neuro-ODE-based model, and we want to try to do some random effects in there in order to get multiple curves that you can simulate from.
Okay. And I was wondering if you tried like a more simple sampling from multi-normal distribution, given the easiest problem that you had here. And maybe also a comment on federated learning. Definitely this is something to use for sharing data in a safe and secure manner. I'm wondering how actually this is related to your generative models, because if you generate data, somehow you have synthetic data, right? So you don't have anymore the problem of privacy, while federated learning allows you to share proprietary data in an encrypted way, right?
Yeah.
Yes.
I think you have to take that discussion in the break. Thank you.
So our third student today, and the second Alex, is Alessandro De Carlo, who is a student at the University of Pavia, where he's doing his PhD in bioengineering and bioinformatics with Professor Paolo Magni. Alessandro is going to be starting his third year as a PhD student next year, so sorry for the recruiters, he's still a PhD student for 1 year. During his PhD, he attended some courses in artificial intelligence, machine learning, and blah, 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 as Siv mentioned. And since attending these courses, he really enjoyed the potential of these techniques, and he's been keen on integrating this with PK/PD modeling. And he's really fascinated by the potential that these techniques have in improving individualized patient care. And the part that I really enjoyed about being a student is being able to choose topics, and in the case of reinforcement learning, being very creative. So he's going to tell us about that now, because the title of his talk is Integrating Reinforcement Learning and PK/PD Modeling to Enable Precision Dosing, a multi-objective optimization for the treatment of polycythemia vera patients with givinostat. Alessandro?
Thank you, Paolo, for the nice introduction, and good morning, everyone. So with this presentation, I'm going to illustrate how the integration of artificial intelligence, and in particular reinforcement learning with PK/PD models, can be used to support precision dosing tasks that are based on patient monitoring. In particular, the first part of the presentation will cover a gentle introduction to reinforcement learning and its application in the context of adaptive dosing strategies. Then, in the second part, the attention will be shifted on an application of this methodology on a real case study. So, let's introduce reinforcement learning. Reinforcement learning is a branch of machine learning that is characterized by a set of algorithms that are used to solve Markov decision processes. A Markov decision process is composed by an agent and a system. In particular, the agent corresponds to the decision maker whose goal consists in driving the system to a certain target condition. And to this end, the agent has a finite set of available actions. Moreover, in this framework, it is assumed that the system is described by a finite set of states, and that agent and system can interact at each step of a given time sequence. More specifically, at time step t, the agent observes the state of the system and then consequently performs a certain action. The process of mapping system state with a given action is called policy, and at the next time step, as a consequence of that action, the system will evolve to a new state and it will return a reward signal to the agent. The reward is merely a real number that can both remunerate or penalize agent action. And in particular, the reward is the output of a so-called reward function that formalizes agent's final goal on the system. And the reward function is one of the most important features of reinforcement learning algorithm, and it should be carefully designed by the users. From a mathematical point of view, solving a Markov decision process means finding the so-called optimal policy, represented by function p star, that associates to each system state the best action, named a star, in order to maximize the expected return, which is represented by this equation. And as we can see, it is the discounted sum of the rewards collected in time. To this end, during the training, the agent has to estimate a certain function named Q function that associates to each state action couple a given score. And therefore, by given the knowledge of the Q function, by applying this equation, is it straightforward to extract the optimal policy P star. One of the most popular reinforcement learning algorithm is Q-learning. Q-learning provides a tabular approximation of the Q function, and in particular, in this framework, the agent is represented by a matrix like this, and as we can see, on the rows of the matrix, we have system states, and on the columns, we have agent action. Therefore, each cell of the matrix contains a score associated to each state action couple. And then, by considering the maximum values along the rows, it is possible to extract a set of decisional rules like those reported in this box. And as we can see, the extracted rules are in the form of if-then-else statement. So it is straightforward to observe that Q-learning algorithm provide a very easy interpretation of the generated rules. This framework of Q-learning, and more generally reinforcement learning, naturally fits to the problem of adaptive dosing strategies. In particular, in this clinical context, the figure of the agent corresponds with the clinician that periodically observes the health status of the patient and then consequently can select a new dose level for the next treatment cycle. But when we move to the artificial intelligence framework, the agent is a computer algorithm, and like all machine learning methods, require a very huge training set in which all possible state action couples for each patient should be contained. But this characteristic cannot be found in real retrospective clinical data set. So at the end of the day, in the proposed framework, the patient was replaced by a digital replica named virtual patient that corresponds with a PKPD model with its personal set of model parameters and covariates. And the model was used to simulate the response after the dose selected by the algorithm. In this way, by leveraging modeling simulations, it is possible to consider all possible dosing strategies during the training of the agent, including also those harmful for the patient that cannot be found or it's unlikely to find in real retrospective data set. This approach was then applied on a real case study, that is the givinostat treatment in polycythemia vera patient. Polycythemia vera is a chronic myeloproliferative neoplasm characterized by excessive levels of platelets, white blood cells, and the hematocrit. The goal of the treatment consists in reaching the complete hematological response, abbreviated CHR, that corresponds to bring the hematological parameters within their normal ranges that are here reported. To this end, clinicians propose an adaptive dosing protocol, which is based on periodically monitor the levels of the hematological parameters. And then, according to their values, a clinician can adjust the dose for the next cycle. One of the most important endpoints of this treatment is the response after 8 months, which is the average time needed to achieve a stable response. In particular, in this context, in which we have a multi-objective treatment, PK/PD models were combined with the Q-learning algorithm in order to personalize the Givinostat protocol for each polycythemic patient. In particular, the first step of the work consists in representing in the Q-learning framework the Givinostat precision dosing problem. And this means representing the state of the patient, the action of the agent, and the reward function. As concerns patient health status, it was represented by a tuple of 4 elements, in which we have the discrete level of the hematological parameters that were split in ranges according to clinical knowledge. Then these discrete values were combined with the information about the previous administered dose. As regards the actions were described accordingly to clinical practice. So Q-learning agent could gradually increase or decrease the previous administered dose, and they also had to respect some safety constraints due to toxicity events such as thrombocytopenia and neutropenia. But on the other hand, Q-learning agents were designed in order to explore different strategies from the clinical protocol, and therefore they could customize on each patient the starting dose and the resumption dose after treatment interruption due to toxicity. The other important features of reinforcement learning that was carefully designed was the reward function, because it has to represent the therapeutic goal of Givinostat. In particular, in this case, it was considered a function characterized by 3 components, one for each hematological parameter. Each of these components is given by the sum of these 3 functions. In particular, the first one was introduced in order to give a higher reward to actions that bring the hematological parameter as close as possible to the middle of the normal range. The second one was introduced in order to give a higher reward to actions that keep the hematological parameter in the normality range for longer time. And finally, the third one was introduced to evaluate the trend of the hematological parameter by considering its first-order derivative. And in particular, in this case, it was given a high reward when the parameter is improving and a negative one when it is worsening. As underlined before, one of the most important features of the proposed framework is using a model to simulate the patient response for each dosing strategies. Therefore, a simulation engine was integrated in a reinforcement learning framework. In particular, Friedberg model was integrated in order to describe the myelosuppressive effect of Givinostat on the platelets, white blood cell, and the hematocrit. So let's now illustrate the obtained results. In particular, at the beginning, the focus was on evaluating the formalization of the Q-learning algorithm, and this step was made at population level. Then the focus was on using this algorithm to personalize treatment in polycythemic patients. So in order to evaluate the robustness of the proposed algorithm, Q-learning was used to learn a single set of adaptive dosing rules. To this end, it was extracted a virtual population of 98 polycythemic patients by using the POP-PKPD model of Givinostat, and then these patients were used to train a single population Q-learning agent, whose goal is learning a single set of adaptive dosing rules. Then, the performances of the population Q-learning agent were compared against the Givinostat protocol on 10 different test sets generated by simulation. Here I reported the results of this comparison. In particular, it was considered the response rate after 8 months of treatment and the time needed to achieve a stable and complete hematological response. As we can see from the bar plot and the table, both strategies achieved very similar performances. And this confirms that the proposed formalization of the algorithm is correct. Moreover, these results underlines the potentialities of Q-learning algorithm that was able to learn from scratch with zero knowledge of the problem, a general adaptive dosing protocol that performs very close to the protocol proposed by the expert of the domain. So then, given this evaluation stage, the second step was to apply Q-learning algorithm in order to personalize treatment in polycythemic patients. In this case, it was extracted a virtual population of 98 polycythemic patients, and then for each virtual patient, it was trained a personal individual Q-learning agent that was used to customize the treatment on that specific patient according to its individual characteristics and covariates. Then this individual-oriented approach was compared against the population Q-learning agent and the clinical protocol proposed by the experts. Here, the three strategies are compared with the criteria seen before. In particular, if we focus on the response rate after 8 months of treatment, we can see that individual Q-learning agent, represented by green bars, outperformed both the clinical protocol and the population Q-learning agent by achieving more than 90% of response rate after 8 months of treatment. In particular, a complete hematological response. That means that all 3 hematological parameters are within their normal ranges. Moreover, this individual-oriented approach based on Q-learning was able to dramatically reduce the time needed for achieve this complete hematological response. So this individual-oriented approach is very powerful, but it has a very strong limitation because this individual Q-learning agent can be applied only if the PKPD model's parameters are known since the beginning of treatment. So the next step of the work was embedding this individual-oriented approach in a Bayesian paradigm, and this led to define the individual Bayesian agents. Within this framework, at the beginning of treatment, when only baseline measurements are available, the starting dose of the treatment is selected with a population Q-learning agent that was previously trained on an external training set. Then, at the end of each treatment cycle, the collected measurements are used to update the individual PKPD parameters with Bayesian map estimation. Then, for that specific patient, given the current knowledge of his or her PKPD parameters, an individual Q-learning agent is trained and then it is used to select the dose for the next cycle. This loop is repeated for each treatment cycle. Then these individual Bayesian Q-learning agents were compared against the population Q-learning agent and the individual-oriented approach under the idealistic scenario in which the PK/PD model parameters are known since the beginning of treatment. Here are reported the performances of these three strategies, and in particular the purple bar represent the performances of Bayesian Q-learning agents, while the green bars represent the performances of Q-learning in the idealistic scenario. And as we can see, the performances achieved in with the Bayesian agents are very close with those achieved by the idealistic scenario. Both strategies were able to allow to reach more than 90% of response, of complete hematological response after 8 months of treatment. On the right, we have the distribution of monthly rewards. The rewards mainly remunerate how the agent is performing. And as we can see, the purple bar represented the Bayesian agent starting from the 4th month become very close to the green one that represents individual Q-learning agent. When we are at the 8th month, both bars are overlapped. So this means that at least 4 months are needed to converge to the idealistic scenario, and 4 months are needed to completely estimate the real values of the model parameters. So the take-home messages of this work are that techniques based on coupling reinforcement learning and PK/PD models are a valid tool for treatment individualization. And in particular, Q-learning is a very efficient and flexible tool when the final goal is correctly described in terms of states, action, and reward function. Moreover, we can state that the integration of reinforcement learning and PK/PD models in a Bayesian framework is a valid and promising solution to apply this individual-oriented approach based on Q-learning on real practice. The next step that are currently ongoing are evaluating this methodology on a wider range of case studies, in particular using a more complex modeling framework in order to consider not only short-term outcomes, but also long-term ones, such as the probability of survival or having adverse events during treatment. Thank you for your attention.
Thanks, Alessandro, for the fascinating presentation. The floor is open for questions.
Like I won the race.
Well done.
Oh, goodness. Build any human predictions. So obviously very interesting work. One of the things that caught me was the design of your, One of the things that caught me was the design of your reward function. When I saw it, it reminded me of a proportional integral differential controller. And I'm curious if you are familiar with those and if you had any thoughts about how the work may be perhaps simplified by looking at that type of control interface rather than the more complex methods you were using here.
Thank you for the question. So I think that using controllers in that case, in which you have 3 different outputs, would be very complicated. While using reinforcement learning, you have only to customize your reward function according to your problem. While when you use controllers, you have to set, for example, the gain and stuff like that, that cannot be very easy to define. While with the reward function, and this is, I think, the most interesting part of the reinforcement learning algorithm, you just need to have clinical knowledge of the pathology. You have to know what is your clinical endpoint that you want to reach with treatment personalization.
Thank you.
Jurgen Loonert from Prometheus. So I have two related questions. So one thing is for the visualization of the performance of the tool, have you considered using cumulative incidence curves? Because that could help clinicians understand what's going on, because you can see both the time and the success in one go. And the second thing is maybe more important. How are you going to break the news to clinicians that this part can be replaced by a computer?
I start from the second one. As I said at the beginning, this is a tool that has to support the decisional process in adaptive dosing strategies, not to replace clinicians. So I think that this is a very unrealistic and utopia. No? The applicative perspective of this methodology that I imagine now is, for example, having a tool with a dashboard and interface that, given the current health status of the patient and his past history, suggests to the clinician what is the next dose level for the next treatment cycle. And the clinician with a certain degree of freedom can say, okay, I trust the tool, no, I do by myself.
Okay, so it's the pharmacist that gets replaced. That's too bad for me.
Nick Holford, University of Auckland. Well, great. That was really got very close to being a clinical application. I mean, you're nearly there. And I would also congratulate you that, at least for the platelet count, you're using something called target concentration intervention, which is much better than TDM. So it's a different talk, but I'm glad to see you're aiming for the center of the range and not saying, okay, if we're within the range, we're okay, we can go back to sleep. That's the TDM approach. There's the politics. The question, though, is about, you only showed the reward function for platelets and not for white cells and hematocrit. Okay. So let me finish the question. So you only showed one, but you can show three. But the question is, how do you weight the contribution of each of these different kinds of cell types?
Okay.
To the reward, because at the end of the day, you have to have a single dose. You can't have 3 doses. This one's for the hematocrit, this one's for the white cells.
Yeah, maybe I wasn't very clear during the presentation. So the reward function, was a sum with the same weight for each hematological parameter, since the goal is normalizing all three at the same time. And for each hematological parameter, that three functions that I showed before were applied. So there were 3 functions for the platelets, 3 functions for the white blood cells, and 3 for the hematocrit.
Okay, so there was equal weighting.
Yeah, equal weighting.
And the last comment, which is really the normal range, you had the normal range for hematocrit was less than 45. That includes 0. So hematocrit of 0 is not normal. So I think you need to go and revise what you think what the normal range would be. Because how do you aim for the center of the normal range if you go between 0 and 45? You're aiming for 22.5, which is definitely abnormal.
Yeah, that were the ranges that clinician, for the hematocrit there is a threshold of 45. Obviously, sorry, when the reward function was designed, it was given a lower reward when the hematocrit went under 20.
Okay.
So it was just
okay. Well, just to finish, I think if your target was 45, that would be much more normal.
Okay.
Not 22.
Thanks, Nick. We have time for one more question.
Hi, thanks for the great talk. Andy Hooker from Uppsala University. I was wondering, first, it seemed like you were training your data sets with 98 simulated patients, and I was wondering why 98 and not 10 million? And the other question was, in the Bayesian loop that you were doing, did you take into account parameter uncertainty in some way? Or were you using point estimates whenever you were updating things?
Okay, so as concerns the first question, 98 patients were selected due to computational costs for training. While during the Bayesian loop, yeah, we accounted the uncertainty of parameters, surely. But the thing is that at the end of the day, one has to select one dose. And by considering all possibilities, you may select different doses due to the uncertainty. So we just computed the map and using those estimates for the selecting the next dose.
Okay, so you were using the map of the individual parameter estimates, so the point estimates then, and not...
Yeah, not the distribution, because at the end you have to make a selection, no?
Yeah.
And then we consider only the mode.
Okay. Thanks again for the nice presentation, and we are moving to the next.
So last but not least, we've got Alexandra this time, and I just wanted to clarify to the audience that we did not pick the students and the abstracts by alphabetical order of the first name. We got the abstracts all anonymized, so we didn't have any names or institutes or anything. So, but yes, back to Alexandra Lavallée-Morel, sorry. She is coming from Paris, and she's nearing the end of her PhD as a student in the group of Franz Montreuil. During the last 3 years, she specialized in joint modeling of longitudinal data and survival data to develop predictive tools for the prognosis of patients hospitalized with severe infections. She especially enjoyed, well, she said every piece of her PhD, from the methodology development, the clinical applications, and also the extension of her work to software packages to spread these methods. So welcome Alexandra, and she'll be presenting a talk on joint modeling of biomarker dynamics and survival with competing risks to predict the prognosis of patients hospitalized with severe infectious diseases. Welcome.
Thank you for the introduction. Thank you also to the committee for giving me the opportunity to present this work. So a main concept in my PhD was the personalized medicine. So that consists in providing every patient with a safe and adapted medical treatment. And in particular, we were interested in predicting the death of hospitalized patients for severe infectious disease. And in this context of hospital data, if we are interested in predicting the death of patients, considering the discharge from hospital as a sensor observation would be incorrect due to the informative character of this event. So that is why in all of this work, we considered computing resetting with the death as the event of interest and the discharge as the computing event. And nowadays, hospitals are equipped with laboratory information systems that routinely gather all the results of biological analysis prescribed by the physician. So consecutive biological observation can be used in a joint model to provide individual dynamic prediction of patient prognosis and to give therapeutic management and to forecast hospital needs. So just a few words about joint models in the literature. So if we look at joint modeling with linear mixed effect model and single event or competing risks, those models are widely developed and their estimation are available in various software with generalist software as R and SAS, or also pharmacometric software as Monolix or NonMem. If we switch the modeling to nonlinear modeling, if we keep one single event, those models are also well developed, but their estimation are mainly available using pharmacometric software as Monolix and NonMem. And now, if we switch to computing resetting, there are very few developments. We found one work that used the NonMem software, and that is why the first work of my PhD was to show that Monolix software can provide unbiased and accurate estimate parameter of such complex model. And we also propose an application on sepsis patients, so if you want further detail on that work, you can find the publication in CPT-PSP journal. But now, if we go further, we can think that shifting the modeling from one single biomarker to potentially many biomarkers can certainly improve prediction accuracy. But it also comes with statistical issues, and that's probably explain why published models are mostly limited with longitudinal model with at most 2 biomarkers. And it highlights the need for a method for variable selection in this context. So to address this question, we worked on a database including 327 patients hospitalized during the first wave of the COVID-19 pandemic. And we had a lot of biomarkers, longitudinal biomarkers available, and also the prognosis of the patient. And the question was how to select the biomarker the most associated with prognosis. So this brings me to present the first objective of this presentation. It's to develop a multivariate joint model and a strategy to select a subset of biomarkers to predict the death of hospitalized patients for COVID-19. In a second objective, a more methodological one, we aim to evaluate the SIM algorithm implemented in Monolix software for this model estimation. And we will also assess the validity of the proposed selection strategy. And finally, as I mentioned before, the estimation of nonlinear joint models is mainly available using pharmacometric software in a frequentist approach. So in this final objective, we want to spread the use of those methods for generalist software, and that is why we extended the R package SIOMX, initially designed to fit nonlinear mixed effect model to the case of multi-responses and joint models. So for the application, as I said, we considered 327 patients hospitalized in France between January and July 2020. We followed 59 biomarkers that we classified into 8 categories that you can see on the right here. We also have the 4C score available, which is a clinical baseline score developed at the beginning of the pandemic to predict the death of COVID-19 patients. You can see those components on the right here. And just to have an idea, in our data, about 14% of the patients died 30 days after admission, and 73% were discharged. So in a univariate approach, we can model each biomarker with a joint model composed of a mixed effect model to describe the biomarker evolution, and of 2 subdistribution function, one for the instantaneous risk of death and the other for the instantaneous risk of discharge, that are both adjusted on the value of the 4C score. And we can link the current predicted biomarker value to both risk using a link coefficient, alpha 1k and alpha 2k. And the structural function describing the biomarker observation can be linear or nonlinear depending on the biomarkers. So this univariate joint model is easily extendable to a multivariate one, in which we consider capital K biomarker. So we have some mixed effect model for each biomarker evolution, and we linked them using capital K link coefficient, so as previously. So from this model, we aim to estimate theta, the vector of population parameters that are composed of longitudinal parameters, and survival 1. And in this work, the inference is done using the SIEM algorithm implemented on monolithic software. So as we hope to derive prognostic information from those biomarkers, the first step is to model them correctly. And we therefore define fit criteria to assign a model to a biomarker that is based on the residual error. And after that, we select a biomarker according to the fact that a biomarker which is difficult to model, so which have a high uncertainty on parameter estimate, will not be included in the multivariate analysis. And we also remove a biomarker which evolution was not significantly associated to the risk of in-hospital death. So for that, we perform a val test on the link coefficient alpha 1K, and we remove biomarker having a p-value over 5%. So all of this process leads to select 22 biomarkers with a linear model and 3 with non-linear model. So after that, the 25 biomarkers were regrouped following the initial classification, and for each group, we only kept the biomarker having the most significant p-value. So that allows us to consider 7 biomarkers in a multivariate joint model, and from that model, we perform backward selection, the first by removing the biomarker having the highest p-value on the link coefficient associated to the death, so on alpha 1K. And we stopped when all the p-value were under 5%. We reach an intermediate multivariate joint model, and from that we repeat the same backward selection, but at this time on the coefficient associated to the discharge. So at the end, we obtain a final multivariate joint model composed of 3 biomarkers, the neutrophils, the pH, and the CRP, that are associated with birth risk of in-hospital death and discharge from hospital. And in particular, we show that an increase of the neutrophil and the CRP and the decrease of the pH was associated with a higher risk of death and a lower risk of discharge. From this model, we also derive dynamic prediction and show very good performances. In particular, we show that this multivariate joint model performed better than a model that only considers baseline information. I will not enter into detail, but if you want further information, you can see the slides of the last year conference. Now I will switch to the methodological objectives, and it is twofold because we aim to evaluate the performances of the estimation and also assess the validity of the proposed selection strategy. So for that, we simulated 100 datasets of 300 patients, 7 biomarkers according to the design of the application, and 2 follow causes, the death, the event 1, and the discharge, the event 2. So in this table, you can find the main characteristic of the simulation. So you can see for each biomarker its longitudinal submodel, its error model, the measurement frequency, and the most important to retain is that we associated with event 1, BM1, BM2, BM3. BM4, BM5 were not associated with the death, but have their slope correlated with other biomarkers, in particular BM2 and BM3 respectively. And BM6, BM7 were not associated with event 1 and not correlated with other biomarkers. So if you just want to have a look about the subdistribution function, they are displayed on the bottom. So for the subdistribution for the risk of death, we included the 3 associated biomarkers, and the baseline risk depend on parameter P1 and G1. And the subdistribution for the competing risk was defined so that the sum of the cumulative incidence function for both events do not exceed 1 at infinite time. So that is why we have not the same expression for the 2 risks. For the objective 1, we estimated the true model on each simulated dataset. So that is to say the joint model with the 3 associated biomarkers. And we assessed the performances using the relative estimation errors. For the second objective, we started by estimating the full multivariate joint model. So that is to say the joint model with the 7 biomarkers. And we performed the backward process on the link coefficient associated to the death, alpha 1K. And for each simulated dataset, we reported the final set of biomarkers. So for the result here, you can find the distribution of relative estimation errors for each model parameters. So for biomarker 1 on the top, biomarker 2, biomarker 3, and survival parameter here. So for linear biomarkers, BM2 and BM3, we obtain very precise and accurate parameter estimates. And for the nonlinear biomarker, the BM1, we observe higher uncertainty on variances of random effects. For survival parameter, the most important are the link coefficient, the 3 link coefficient here. And we observe moderate uncertainty, but given the complexity of the modeling, we can say that we obtain quite good performances. And after running the backward process on all the simulation, we found that 74% of the replicates found the correct set of biomarkers, and 20% found only 2 associated ones. The other cases, so very few cases, added a biomarker that was either correlated or unassociated. So overall, the backward strategy led to very good performances in our example. And finally, I will have a few words about the last project, in which we aim to spread the use of those methods in more generalist software. So to recall, we extended the SRMX package to the case of joint models. It was not straightforward, but the main idea was to redefine the likelihood expression to allow for multiple outcomes. And one thing important is that we implemented an algorithm to estimate the Fisher information matrix to derive standard errors of parameter estimates. And in the context of joint models, the FIM is usually computed by stochastic approximations. So, for example, the monolithic software used the Lewis method, which has some disadvantage. And very recently, a new alternative stochastic algorithm was developed by some authors, and they show interesting properties, in particular about the computational time. But they did not yet evaluated this algorithm for joint model estimation. So that is why I will present you a simulation study to answer 2 objectives. The first is to evaluate our extension for the estimation of parameter of joint models. And in the second objective, we also aim to evaluate the standard errors estimation using this new algorithm. So for that, we consider 4 joint models with linear or nonlinear mixed effect model and with single or competing risks. And for each of the 4 models, we simulated 100 data set of 100 patients. So the model equation are displayed here. Very quickly, the linear mixed effect model and the nonlinear mixed effect model are the same as I presented in the real case application. And for a single event joint model, we consider a baseline risk H0 and the link coefficient alpha. For competing risk models, they are also the same equation that I presented previously. So I will not detail once again. To assess the parameter estimation, we compute the relative estimation errors, and to assess the standard error estimation, we compare the stochastic RSE that we obtain using the new algorithm with the empirical one that we computed over all the replicates. So here you can find the result for joint model with linear mixed effect model and time to event, a single event on the left and competing risks on the right. So on the top you can find the distribution of relative estimation errors, and on the bottom the distribution of stochastic RSE versus the empirical one in red point. So here for both models we obtain very precise and accurate parameter estimates, and also the mean distribution of the stochastic RSE are very close to the empirical one, so the estimation process performs well for both parameter and standard errors. And now, if we switch to nonlinear modeling, you can observe the same trends as in monolithic software with higher uncertainty on variances of random effects. And for those parameters, also the standard, the stochastic accuracy are a little bit underestimated. However, if you look at the link coefficient, which is of particular interest, we show very good performances of estimation for both parameter and standard errors. So to conclude on this work, on the real case application on COVID-19 patients, we developed a multivariate joint model to predict the death of hospitalized patients and a strategy to select among various biomarkers. We show that the evolution of neutrophils, pH, and CRP were predictive of the death and the discharge of patients. So this tool can be used in many other applications to identify biomarkers in other diseases. In a methodological point of view, we show that monolithic software provides unbiased and accurate parameter estimates, and that the backward strategy leads to good performances. However, there are some limitations because only a limited number of biomarkers can be considered in the multivariate joint model because, as you can see on the right, the CPU time spent to estimate a joint model increases faster as the number of biomarkers increases, and this is mainly due to the standard error estimation. So considering a too large set of biomarkers in the multivariate joint model would be inappropriate. And finally, we know that backward strategies are usually outperformed by penalized regression methods. So that's why a future extension may be to include a lasso penalization in such model. And in the last project, we extended the error package SRMX to the case of joint models. We show good properties of estimation for parameter and standard errors. So this is a very flexible parametric tool in joint model framework. And the advantage is that the user defines the likelihood of the model they need, so very specific joint models can be considered. We also need to evaluate the estimation in other settings and develop some goodness of features to extend the whole package. However, if you want to test some function, to see some example, you can find all the code and the function available on GitHub at the following address. Thank you.
Thank you very much for the talk. Again, it's open for questions now, and please introduce yourself with your name and affiliation. Thank you.
Stefan Schmidt, University of Florida. Very nice talk. I have two questions. Number one is you considered a longitudinal scenario. What did you choose as your starting time? Was it time since hospitalization, or was it time since supposed start of infection? So in other words, did you consider the severity of the disease once you started your hazard function?
So we consider the time since the hospital admission. So we perform all the analysis given that, and we did not consider any scenario. But it might be interesting also to see other cases.
Yeah. Okay. My second question is, I suspect once the patients were in the hospital, they were also undergoing treatment with, for example, antiretrovirals. Again, did you potentially consider the onset of treatment relative to the severity of the disease? Because many antiretrovirals go intracellular phosphorylation steps, and as it happens, SARS-CoV-2 uses the same phosphorylation. In other words, you enter in a competition between antiviral efficacy and the virus making in and by itself, and so you have a limited time of opportunity to have effective treatment.
Yeah, that's a very interesting comment. In fact, in the database we also have treatment information, but there was very different treatments for each patient. So it was too complicated to include this type of information. However, with discussion with clinicians, it would be also interesting to make treatment categories, but we did not use it for the moment.
We can only take one more question now, sorry.
Okay, so it's a very quick question. Can you explain why you used urea as a biomarker and not creatinine?
Why?
Why you, in your list of biomarkers, they all seem reasonable, age and so forth, but you used urea rather as presumably as a marker of renal function, but the usual marker of renal function would be creatinine. So my question is, why did you use urea and not creatinine?
So we didn't have all the biomarker available, and just 59 biomarkers, and we performed the strategy according to clinical consideration, but also statistical methodology. And in a statistical point of view, the creatinine was not do not appear. So
okay. I thought you concluded that urea was not a meaningful covariate. Okay, well, we can talk about
yeah,
that.
we'll
But
talk,
anyway, which is a strange choice, anyway.
Yeah, okay.
And just a quick comment about the wall test. Franz Montré teaches that the wall test is a very bad way of model selection. Depending on how you choose, you calculate the confidence interval.
Yeah.
You should tell us how you did that.
I totally agree, but as the patient do not have the same measurement times, this is not possible to use other, for example, LRT tests to compare the biomarkers. So this is one method that we choose.
So we would like to have all the awardees coming up to the stage to receive their prizes, and we would like the audience to stay as well and honor these excellent students. So now it's time for coffee break and poster session. We would like to have you back here at 11:45. Thank you, everyone.
So we gotta move.